Computerized adaptive testing for depression and anxiety amongst adolescents in African populations, the AfriCAT-DA proposal. In this presentation, we'll cover who the team is, what we propose to do and why, how we plan to deliver the project, and finally, the potential for scalability and social impact. Our team brings together diverse expertise in mental health, data science, and lived experience, with 6 out of 9 co-applicants coming from African institutions in South Africa and Kenya. Dr. Bianca Moffett and Dr. Mary Bitta are clinician researchers with over 10 years' experience in rural, primary, and community-based mental health care in South Africa and Kenya, respectively. Darryn Williams is a senior data scientist based in Johannesburg, South Africa, and lived experience expert consultant with the Global Mental Health Peer Network. Prof. Hartley and Prof. Robbert Gibbons bring specialized expertise in advanced statistical techniques and novel machine learning applications, and are committed to building capacity amongst African data scientists and researchers. Gibbons is a pioneer in computerized adaptive testing for mental health applications. Prof. Holly Erskine and Prof. Mark Tomlinson bring expertise in psychiatric and life course epidemiology, respectively, and are the principal investigators of 2 studies from which source data originates. Dr. Pozuelo has a background in behavioral economics and psychiatry, and Prof. Alastair van Heerden brings considerable expertise in digital and AI global health applications. So what do we propose to do and why? Adolescent depression and anxiety is a neglected health priority. This is true globally, but particularly in Africa, where we face 2 key problems. First of all, there is a lack of robust epidemiological data. However, existing estimates suggest that up to 30% of adolescents have depression and anxiety. We also know that there are an abundance of risk factors for mental health conditions, such as being female, being exposed to poverty, food insecurity, HIV, not being enrolled in school, trauma, and being an orphan. Secondly, there is a pervasive lack of adolescent mental health services. So whilst effective treatments for depression and anxiety exist, most adolescents with depression and anxiety remain undiagnosed and untreated. Diagnosis or identification is a critical step in the care pathway. So why are so many people undiagnosed? Some of the key reasons are the lack of mental health professionals, low attendance of adolescents at health facilities, our reliance on gatekeepers such as parents or teachers to pick up mental health problems amongst adolescents, stigma and lack of awareness of mental health conditions, and lack of access to effective treatments can also inhibit diagnosis. The use of brief validated mental health screening or diagnostic tools could address this gap. Several calls have been made to implement mental health screening in primary healthcare settings and schools, on the basis that this could overcome human resource limitations and enable early identification and treatment. A large number of tools have been developed to this end, including over 280 instruments for depression alone. Many of these tools have reasonable diagnostic predictive accuracy. However, existing tools have not been widely implemented in routine care settings and do have certain limitations. One of the key reasons for this is the need to match supply with demand. Mental health screening should always be accompanied with development of services so that people who are assessed as having a condition are able to access effective treatment. Other reasons include many of these tools actually have limited construct validity. Construct validity is whether the tool actually measures the construct that it intends to measure. Many mental health constructs are what we call latent. That is, they're not directly observable or measurable in the same way that, for example, weight or height are, and they're actually made up of several dimensions. For example, the construct of depression is made up by changes in mood, cognition, and physical symptoms. Some mental health measures don't account for this multidimensionality of the mental health constructs and only use a small number of items, and the measures don't account for the differential functioning of the various items. Mental health measures should also be brief, accessible, and ensure privacy and confidentiality to ensure that they're used by users and providers. Another feature of mental health conditions that makes it difficult to select single measures is the presence of mental health comorbidities and a lot of diagnostic overlap between conditions, meaning that policymakers and providers may have to choose between screening instruments for various conditions. Furthermore, policymakers and providers may feel that they have several competing health priorities such as HIV, chronic diseases, and mental health conditions, and are not able to screen for each disorder. And finally, there's a need for comparability of measures so that data can be pulled across studies for meta-analysis. And this is challenged by having numerous different measures. Computerized adaptive testing is a novel paradigm of testing for mental health conditions based on advanced statistical methods and machine learning techniques to allow for more personalized, precise, efficient, and scalable screening and diagnostic assessment of mental health conditions. So how do CATs work? Well, they draw on large item banks of individual questions taken from a variety of mental health scales. Individual items are calibrated based on their psychometric properties and performance in the population of interest. After each item is administered, a severity score and precision estimate is generated, and subsequent items are adaptively selected based on the individual's response to the previous item, with the goal being to optimize precision of measurement whilst using the least possible number of items. Testing continues until a pre-specified precision level is achieved. And CATs are administered through a graphical user interface so that they can be self-administered or provider-administered. Total severity scores and precision levels are automatically generated. Comparing non-adaptive tests to CATs. Non-adaptive tests, such as the PHQ-9, are based on classical test theory. They use a limited number of items to measure mental health constructs and assume that all items contribute equally. They administer the same set of items to each participant. So they use a fixed number of items with variable precision and are mostly used for screening. Computerized adaptive tests, such as the AfriCAT-DA, are based on item response theory. They draw on large item banks pulled from a number of symptom scales and acknowledge that some items are better at discriminating cases and severity than others. They vary the number and content of items administered to each participant. They have a fixed precision but a variable number of items, and they can be used for screening as well as for diagnosis. Advantages of CATs are that they are personalized, precise, efficient, highly scalable, and ideal for monitoring because items can be varied at each time point, whilst maintaining high test-retest reliability. This feature also makes them ideal for longitudinal research and interventional studies. Some interesting use cases of CATs include their use in the USA and the UK. In the USA, they've been used in primary healthcare settings, emergency departments, and correctional facilities for adult and adolescent populations. One example of this is their use in the UCLA STAN program, where they were used to screen and triage over 6,000 students into stratified care. In the UK, Artemis-A, developed by a team of researchers at Cambridge University, is a computerized adaptive test for mental health challenges amongst high school adolescents. This proposal aims to develop a computerized adaptive test for depression and anxiety amongst adolescents using existing data from African populations. Our specific objectives are, first of all, to develop the test and secondly, to assess its efficiency and precision compared to non-adaptive instruments. And our hypothesis is that the AfriCAT-DA will be both more precise and efficient than the non-adaptive measures. How do we intend to do this? This study will utilize data from 4 adolescent mental health surveys conducted in South Africa and Kenya that contain measures of depression and anxiety, socioeconomic variables and risk factors associated with mental health conditions, and gold standard diagnostic measures for assessing depression and anxiety amongst adolescents. A subset of the data will be used for the first objective to develop the tool, and the remaining data will be used to simulate a validation study. The features of the individual datasets are given in this table. You can see that there are a variety of study designs, including 2 studies that are cross-sectional surveys and 2 which use baseline data from pilot randomized control trials. All studies involve adolescent populations with some variation in the age groups. And all studies include outcomes of depression and anxiety, although there's some variation in the other mental health constructs that are also measured. Following the implementation of data transfer agreements, data will be stored on a secure server at the University of Witwatersrand, and data harmonization will follow the following steps. First of all, familiarization with the individual data sets. Secondly, preliminary data cleaning. Standardizing the variable names. However, we will not attempt to transform and standardize non-identical measures of the same construct, as this would interfere with the study objectives. Then we will append the data sets together, stacking them on top of each other, and explore the combined analytical dataset. A subset of the data will be used to develop the tool. Using the MERT approach, this will involve generating the item bank, classifying the items into meaningful subdomains, calibrating the individual items, and generating severity estimates to attach to each item along with a precision estimate, and then selection of the CAT algorithm by using simulated CATs to develop the adaptive tests based on numerous possible combinations of CAT tuning parameters, and finally developing a graphical user interface. We will also assess an alternate modeling approach using modular decision support networks. MODIN is a novel decision tree comprised of a collection of question-specific neural network modules that can be combined in any number or combination to make any number or combination of diagnostic predictions. Similar to the MERT-based CAT process, this modularity allows for adaptive administration of the items and prediction of the diagnosis and severity after each new item is administered. Our second objective is to assess the validity of the AfriCAT-DA by comparing it to gold standard measures in the dataset and non-adaptive measures. The metrics of evaluation will be the diagnostic predictive accuracy based on the sensitivity, specificity, and area under the receiver operating curve, and the efficiency of the measure based on the number of items and the time taken to administer it, and its convergent validity with the other measures. Community, stakeholder, and lived experience engagement will be conducted to ensure that the tool meets the needs of users, that we optimize uptake and dissemination of project insights and outputs, and enhance research efficiency and foster collaboration. We have planned community and stakeholder engagement workshops in Nairobi and Cape Town, where the majority of the data for this study was collected. We'll also conduct workshops with adolescents with lived experience from these sites to integrate their insights into tool development, and will engage the mental health research community. The feasibility of the project is optimized by ensuring a good match between the scope, time, and budget. Also, by using data that's already collected and cleaned, having adequate expertise and know-how on the team, and being able to afford input from these subject matter experts, as well as input from co-investigators from the source studies. A detailed timeline with milestones was provided in the proposal, along with a description of which co-investigators will lead the work encompassed in each milestone. Key risks involved in this project include breaches to data privacy and confidentiality, and risk of encoding bias into the CAT algorithm, which can be mitigated as described in the table. There are also several theoretical risks to the administration of the AfriCAT-DA tool, although it should be noted that we've not planned to deliver the tool to participants during the scope of this project. These would include self-diagnosis or medication, over or underdiagnosis, stigma, and importantly, a mismatch between demand for mental health treatment if screening is implemented at scale and supply of effective evidence-based treatments. Widespread screening without linkage to care is ethically questionable. Therefore, balancing these risks with the benefits of open science, we propose that the analytical dataset and source code for the AfriCAT-DA tool are made accessible to other researchers. However, the user interface is not immediately made publicly accessible until further investigation has been conducted. Scalability and impact. The key output of this work is the AfriCAT-DA tool, a scalable digital tool to assess depression and anxiety amongst adolescents. Moving forward, we propose further research on the AfriCAT-DA tool, including a prospective validation study, validation in other African populations, followed by interventional research to assess the effectiveness of screening when it's linked to care, as well as implementation research to investigate the ideal method and platform of administration, as well as the user and provider uptake of the tool. Additional modules such as suicide and substance use could be added to the tool. The clinical applications for the tool are widespread, but include integration into school-based programs and healthcare settings, and integration with digital treatments or stepped care models. Research applications include large population-based studies, where, for example, the tool could be used for mental health screening within health and demographic surveillance sites, and its use in longitudinal research, including cohort studies and interventional trials. In conclusion, the limitations of the study are that the scope is restricted to what's feasible to do in 12 months. There are limitations of the existing data, including the number and variety of measures, and we will use data from only 2 middle-income African countries. However, the strengths of the study is that it's feasible, a significant first step with very clear next steps. It's efficient, uses existing data, tailored to African adolescents, has an explicit focus on gender and equity, uses robust statistical and machine learning methods, and has strong expertise within the study team. Finally, the AfriCAT-DA tool could be a novel innovation with immense potential for future clinical and research applications. Integrated into school-based or digital programs, it could inform a scalable and sustainable model for adolescent mental health diagnosis and care.